virtual platform to share with you the story of Dapagliflozin. Now, I've had the great privilege of being involved in the Dapagliflozin program, the empagliflozin program, and in many of the studies that have been reported. But the purpose of today's program specifically is to discuss the role of dapagliflozin across the continuum of cardiorenal protection. I won't have time to go over all of the data on SGLT2 inhibitors in the various cardiorenal studies, but I will focus specifically on dapagliflozin for today's discussion. And shown here are my disclosures. Now, I'm sure you will agree with me that no matter where you live in the world, we are facing a real tsunami of diabetes, chronic kidney disease, and heart failure. We know that these three diseases speak to each other pathophysiologically. We know that these three diseases speak to each other prognostically. And we also know that they coexist in many patients, one follows the next in no particular sequence in patients with cardiorenal risk factors. Now, SGLT2 inhibitors, of course, have revolutionized the management of diabetes throughout the world. They were discovered not only for glucose lowering, but have now been demonstrated to be profoundly effective therapies to prevent and treat renal disease and to prevent and treat heart failure with and without diabetes. And I'm going to tell you the story of SGLT2 inhibitors and its real, serendipitous, story with respect to cardiorenal risk across the spectrum. Now, to be able to tell the story, let's start with the patient. And this is a patient, Mrs. Aaliyah. She's a 62-year-old female librarian who has 2 years of diabetes. The brother had bypass surgery at 44, no known history of coronary disease, just has a history of hypertension. Her BMI is 26, A1C is 7.8%, LDL is 2.6 millimole, blood pressure is 132/78, GFR is 74, and she's completely asymptomatic. She's on metformin, perindopril, atorvastatin, and ezetimibe. So essentially, this is a patient with type 2 diabetes who has relatively newly diagnosed diabetes with no known history of vascular disease, who has multiple risk factors, in this case, hypertension, dyslipidemia, and mild obesity, if I may, with a BMI of 26. So the question is Mrs. Aaliyah your patient? And of course, we see these kinds of patients all the time. I see less of these kinds of patients. I see more patients with established disease, but many of you see these kinds of patients early on in their journey of diabetes. So in 2019, when we wrote this paper in The Lancet, I did not realize that this would become such a catchy phrase, that diabetes affects the pump, the pipes, and the filter, but it really caught the attention of all of us in terms of how do we describe risk factors and outcomes in patients with diabetes. We know that diabetes leads to heart failure. It leads to heart failure independent of its effects on coronary disease. We know that diabetes leads to atherosclerosis affecting the pipes, and we know that it affects the kidney. And really, when we're choosing therapies in people with diabetes, we must be cognizant that not all therapies that lower glucose affect the pump, the pipe, and the filter. And that is a key message moving forward about how do we pick and choose and prioritize agents that are cardiorenally protective. There's no point in using drugs that lower sugar that don't have benefits across these axes. And I think that is a key message echoed in the worldwide guidelines with diabetes today. Now, as they say, what you sow is what you reap. You reap what you sow. The choices that you make today will influence the outcome tomorrow. And it's in that vein that we think about now the 4 diabetes SGLT2 inhibitor trials that have been completed. EMPA-REG Outcome and Vertis in secondary prevention, Canvas and Declare, which used a mixed population of primary and secondary prevention patients with diabetes, as you can see here, as shown in this slide. In the Declare TIMI 58 trial, 60% of patients had diabetes and multiple risk factors without established cardiovascular disease. And in the Declare TIMI 58 study, we also enrolled people with a GFR above 60 mils per minute. And therefore, as you go from left to right, you see that we have had a real great representation of trials in diabetes across different cardiorenal risk. Now, I'd like to spend a few minutes, as I said, discussing the Dapagliflozin story. And the Declare TIMI 58 study still stands as one of the largest trials that has been done thus far from diabetes and cardiovascular outcome standpoint. 17,160 patients were evaluated in this study, as you can see here. And these were patients with type 2 diabetes. About 10,000 of them were primary prevention, 7,000 were secondary prevention, randomized to dapagliflozin versus placebo in an event-driven trial that demonstrated that there was a significant reduction in the composite of cardiovascular death and heart failure hospitalization with a p-value of 0.005 for superiority of dapagliflozin versus placebo. And there was a numeric reduction in the entire cohort of 7% in MACE. This was statistically significant only in the secondary prevention population that I will discuss, but was not statistically significantly better in the entire cohort. So this was real exciting news that you could take people with diabetes like Mrs. Aaliyah early on in the journey of diabetes and give them an agent that can prevent them from developing heart failure outcomes, i.e. CV death or hospitalization for heart failure. Now, when we look at the renal outcomes in the Declare TIMI 58 trial, they were just as stunning. In fact, when you look at the renal composite outcome, which comprised a 40% decline in eGFR, end-stage renal disease, renal or cardiovascular death, that was reduced by 24% with dapagliflozin versus placebo. And please remember that we enrolled patients with GFRs above 60. In fact, the mean GFR was 85 mils per minute. So this was, again, great news that you can prevent disease, you can prevent renal outcomes, you can prevent heart failure outcomes before they become manifest in people with diabetes if you start this therapy early. Now, what was incredibly important was that this benefit to reduce the composite of CV death and heart failure hospitalizations was observed consistently in the patients with primary and secondary prevention, as listed here. There was really no heterogeneity. Everybody derived that benefit, whereas people with established cardiovascular disease were the ones where there tended to be a greater reduction in MACE risk. And I will discuss that in the next few slides. We also found that dapagliflozin was equally effective, irrespective of whether or not people had a prior history of heart failure. So not just a diabetic patient with a history of heart failure, but even a patient with diabetes with no history of heart failure derived a benefit. So if a patient with diabetes was treated early with dapagliflozin, whether they had renal disease or not, whether they had heart failure or not, whether they had coronary disease or not, it didn't matter. If you just had risk factors, you still derived the same benefit across the spectrum. Now, we have tried to risk stratify this population, and at 2019, at the European Society of Cardiology Congress, you can see Professor Berg presented data based on risk stratification across the TIMI risk score for heart failure. And if you have patients with diabetes who have a history of heart failure, atrial fibrillation, coronary disease, or low GFR or spilling protein, that accounts for a large risk of heart failure in this population. In fact, if you look at eGFR below 60 and a UACR consistent with micro or macroalbuminuria, 50% of the score-based prediction of heart failure can be gleaned through the lens of the kidney. And when you look at the efficacy of dapagliflozin, was associated with greater absolute risk reduction for the outcome of heart failure hospitalizations in patients with greater risk of baseline heart failure, but the relative benefits were consistent across the groups. And this again is an important message that it doesn't matter what level of risk patients are at, they all seem to derive a consistent benefit of dapagliflozin in this regard. Now, the most important analyses that I think that was done from this was looking at people with a history of prior MI. And I really would like your close attention to this slide because a lot of people talk about MACE risk with DECLARE. And in fact, when you do look at patients with a prior history of myocardial infarction, the secondary prevention patients, similar to the patients that were enrolled in the EMPA-REG outcome trial, you actually see that patients with a prior MI derived a statistically significant benefit with a hazard ratio of 0.84 that was entirely consistent with what we found in the EMPA-REG outcome in the secondary prevention cohort. So the message is that dapagliflozin does indeed reduce MACE events. It does indeed reduce MACE events similarly to what was reduced in EMPA-REG outcome in patients with a history of a prior myocardial infarction. Now, what about the safety? Of course, we know that genital infections occur with these agents and can be prevented with good genital hygiene. There can be a slight excess of diabetic ketoacidosis, but again, that is something that all of you as endocrinologists know very well, how to treat and how to manage and how to prevent. But otherwise, there's no excess of bladder cancer or no excess of serious adverse events or major hypoglycemia. In fact, is lower numerically with dapagliflozin. There is, in fact, numerically lower rates of bladder cancer. So, really very well tolerated therapy per se. Now, let's talk a bit about urinary tract and genital tract infections. There was no excess in UTIs. There was an excess in genital tract infections, and there was no excess in Fournier's gangrene. Now, what about using it in patients with a history of PAD? And as you know, patients with peripheral arterial disease are at very high risk of cardiovascular events. And what we found in this analysis was quite interesting, is that in patients with peripheral arterial disease enrolled in the dapagliflozin trial, that there was a consistent benefit. In fact, if you look at the rates of CV death or heart failure hospitalization, the absolute benefit seemed to be higher in patients with peripheral arterial disease compared to those patients without peripheral arterial disease. So there should be no hesitation, colleagues, in using dapagliflozin in a patient with PAD. In fact, there is no excess risk of amputation for acute or chronic limb ischemia, or amputation for infection that is observed in this cohort. Now, atrial fibrillation and atrial flutter remain important cardiovascular outcomes, and Dr. Thomas Zellniker from the TIMI group has recently evaluated whether dapagliflozin can prevent a new atrial fibrillation in the DECLARE trial. And in this post hoc exploratory analyses, you see a close to 20% reduction in the incidence of AFib or aflutter in patients with diabetes who did not have AFib, who were then treated with this medication moving forward. Now, a very important concept is prevention of renal outcomes. And I think as endocrinologists, you very well appreciate how important it is to reduce kidney outcomes in people with diabetes, particularly prevent renal decline. And this is one of my really key slides for today. I ask for your kind attention to this slide because it demonstrates that in the DECLARE study, those patients who received dapagliflozin, remember the baseline GFR was 85 or so, that there was a 47% highly statistically significant benefit on the renal specific outcome. We almost cut renal outcomes by 50% on top of standard of care. And this included doubling of serum creatinine, end-stage renal disease, and renal death. Now, the population globally is getting older, and therefore the efficacy and safety of therapies in the elderly population remains a very, very important question. And in fact, in this analysis done by Dr. Avitat Khan from the TIMI group, you can see that the therapy was really effective in elderly people without any excess in volume depletion. In fact, there was less volume depletion in people who were elderly taking dapagliflozin, and there was markedly less acute kidney injury in people over the age of 75. So again, a reassurance that the therapy can be used safely in people who are elderly. Now, what about using dapagliflozin across the continuum of risk as defined by the TIMI group? And as you can see here, whether you look at the outcome of MACE, whether you look at the outcome of CV death or heart failure, or you look at the renal specific outcome, that there is a much greater return in patients who are in the high risk category. The greater the number of risk factors, the higher is the risk of diabetic patients for MACE, for heart failure, and for renal disease, and the greater is the benefit of dapagliflozin. Now, what about patients who are obese, who have diabetes? And this recent analysis, and I wrote the editorial to this in the European Heart Journal, and you can see that when we think about heart failure hospitalizations in diabetes, as you go from, an increase in BMI from normal to moderate to obese to very obese, the risk of heart failure hospitalizations goes up markedly. But the absolute risk reduction and benefit of dapagliflozin is greater in patients as their BMI increases as well. So when we take this all in its totality, what have we learned? We have learned that dapagliflozin irrespective of the type of patient, whether they're secondary prevention, post-MI, primary prevention with diabetes, that dapagliflozin reduces the rates of CV death and heart failure across the spectrum. It reduces the rates of renal disease across the spectrum. But when it comes to reduction in MACE events, it also reduces MACE events, and it reduces MACE events with a number needed to treat that is lower than the number needed to treat for heart failure in patients who have had a prior myocardial infarction. So SGLT2 inhibitors and dapagliflozin do cover the entire spectrum. Therefore, in Canada, dapagliflozin is indicated by Health Canada to reduce the risk of heart failure hospitalization in adults with type 2 diabetes in primary or secondary prevention. And the United States FDA has given an indication for dapagliflozin in type 2 diabetes to reduce the risk of hospitalizations for heart failure in primary or secondary prevention. So this is not restricted to secondary prevention. This is for all comers with diabetes. So when we wrote this editorial in the Cell Metabolism, I think this truly is reflective of a big win for cardiorenal disease and diabetes. Can we declare a victory against cardiorenal disease in diabetes? So now when we look at Mrs. Aaliyah, you wonder, does she fulfill the declared TIMI 58 criteria? And the answer, of course, is yes. Now, DPP-4 inhibitors, you could ask, should they be used? I think they're safe drugs. They're neutral drugs when it comes to MACE. They are neutral for heart failure, except for saxagliptin, as you know, that is associated with an increase in heart failure and has not been recommended in people with heart failure and diabetes. And when it comes to renal benefits, they really don't have any hard renal benefits. So I know there's a lot of use of DPP-4 inhibitors, and they have their place and they have their appropriate place. But I think that, as the gatekeepers of the patient's best outcome, we are not marketers, we are not salesmen. We are given the responsibility to do the right thing for the patient. And when thinking about that right thing for the patient, these drugs are safe, which is wonderful, but they do not have the same kind of gravitas as SGLT2 inhibitors do. And you see that DPP-4 inhibitors in all of the trials have shown a neutral outcome with respect to cardiovascular risk, and heart failure hospitalizations in the SAVOR-TIMI 53 study seem to be increased, unfortunately. But with all of the other studies, including sitagliptin and linagliptin and some of the other agents, that excess risk has not been seen. Now, what about GLP-1RAs? They're also wonderful agents. They're superior with respect to MACE reduction. They are neutral on heart failure, and even for renal benefits, they don't reduce hard renal benefits. This mostly albuminuria reductions. So that brings us to the question that why should we care about heart failure and diabetes? And, many health professionals and endocrinologists ask me, why is it important and relevant to my practice? Well, heart failure is going to be a cause of mortality in a large number of individuals, continues to be a dominant mechanism of mortality throughout the developing and developed worlds. And therefore, the prevention of this is incredibly important. It's the job of the primary care doctor, the endocrinologist, the cardiologist. Everyone needs to keep their eye on prevention of this really important complication. We know that diabetes, through various mechanisms listed here, can lead to atherosclerotic cardiovascular events. And at the same time, diabetes can also lead to direct effects at the level of the pump. And the effects can then culminate into increased ischemic risk, increased heart failure risk, and of course, increased renal risk, which accelerates vascular risk and accelerates heart failure events. Heart failure and diabetes is common. It is disabling. There's a very high rate of subclinical heart failure, not diagnosed, and that's diastolic dysfunction. And we know that DPP-4 inhibitors are relatively neutral for this outcome. Now, it is important for all of you to recognize that we classify heart failure in different stages today, with stage A, B, C, D, with stage C really being dominant established heart failure. But stage A and B are really asymptomatic pre-heart failure stages. Endocrinologists have a lot of these patients that are pre-heart failure. And please remember that pre-heart failure patients in A and B stages, actually diabetes is one of the strongest risk factors for the transition from pre-heart failure to established heart failure. Now, why is heart failure important? Because when a diabetic patient develops heart failure, their prognosis is the worst compared to any of the other risk factors, as shown here in red. Whether you've had diabetes for 1 year or 3 years or 5 years or 7 years or 10 years, if you have heart failure, your outcome of death is worse than having ischemic heart disease, PAD, chronic kidney disease, or stroke. So when we think about this problem, diabetes affects the pump, the pipes, and the filter. SGLT2 inhibitors should be viewed as the statins of the 21st century. Really, as statins reduce atherosclerotic events, SGLT2 inhibitors are profound therapies to prevent and treat heart failure and renal events. So friends, 10 years have gone by for Mrs. Aliyah, and she now shows up back to your office. She's now 10 years older. She's 72. She's had 12 years of diabetes. She still has a history of hypertension, but life changed in 10 years for Miss Aliyah. She had a heart attack 5 years ago. She has had heart failure hospitalization. Her GFR is down to 45 and her ejection fraction is down to 33%. This is a disaster for this patient in terms of prognosis. She's gained weight, BMI is 30, LDL is better. She has had all of the cardiorenal complications. She's on metformin, sitagliptin, gliclazide for diabetes. For heart failure with a reduced ejection fraction, she's on an ACE inhibitor, a beta blocker, and an MRA. And for her lipids, she's on atorvastatin and ezetimibe. So as they say, choices matter. If we had made a different choice for her 10 years ago, maybe we could have prevented the heart failure outcomes, the renal outcomes, and the MACE outcomes. And I think that's something for us to reflect at. So the question is, can we do better? Can we now intervene in this patient? So this is a very important situation. Can these drugs be used to treat heart failure? Can they be used to treat established HFrEF rather than just prevent it, as we saw in the DECLARE study? And can these benefits be seen in people without diabetes as well? These are two fundamentally important questions. And we asked this question in the DAPA-HF trial, and I was delighted to be part of the leadership of this trial. We published this in the New England Journal, November 21st, 2019, demonstrating that when we gave dapagliflozin to patients like Miss Aliyah with heart failure and a reduced ejection fraction, with or without diabetes, there was a highly statistically significant 26% reduction in the outcome of heart failure and CV death. This was a game changer, absolute game changer for HFrEF. We also found, colleagues, that all-cause death was reduced by 17%, and that was statistically significant. Along with Professor Petri and I, we co-led the analyses looking at people without diabetes, and we published this in JAMA in 2020, where we demonstrated that dapagliflozin's benefit was completely independent of whether people had diabetes or not. Whether their A1C was 5 or 7 or 10 or 12, it did not matter. The benefit was seen across every patient, irrespective of their hemoglobin A1C. We also found that the medication reduced outcomes very quickly. By day 27, there was a statistically significant benefit to be seen. Less than a month, and the cardiovascular outcomes were different. Now, something that we are really excited about, that we were discussing a few minutes earlier, is this paper that we published earlier last year, actually about a year ago now, in Diabetes Care. And that was looking at whether we could prevent diabetes with these agents. And in fact, what we found was that when we gave dapagliflozin to people without diabetes, who may have had pre-diabetes in the DAPA-HF trial, there was a 32% reduction in the transition to new diabetes. So I'm not suggesting that you use it in non-diabetic patients to prevent diabetes, but in patients with heart failure, there is now a real excitement that these drugs can prevent the development of new diabetes. So along with Professor Braunwald, as you know, world-renowned, Braunwald's internal medicine, you all know Professor Braunwald from Harvard Medical School, myself and Dr. Batt, we wrote the DAPA-HF trial, a momentous victory in the war against heart failure, because it changed the world. It changed the way in which we treated HFrEF, saying that dapagliflozin is now a foundational therapy for people with or without diabetes to treat HFrEF. And it immediately led to a change in the United States FDA guidance that said dapagliflozin should be used not only in diabetes, but also in patients with heart failure with a reduced ejection fraction, irrespective of diabetes status. So then finally, the last 2 minutes or 5 minutes, I promise, max, the story of dapagliflozin continues. And in DAPA-CKD, as we've said, the beginning of a new era in renal protection. And what a profound observation that people with or without diabetes, with chronic kidney disease, that dapagliflozin reduced by 40% the primary composite cardiorenal outcome with a p-value of 0.000000028. And that is a highly persuasive p-value with a massive relative risk reduction, with similar benefits seen in people with and without diabetes. And what about all-cause mortality? I want to pause just for 1 minute and just star this, because I want you all to reflect on what this slide is, that in a patient with chronic kidney disease, with or without diabetes, who is on an ACE inhibitor, by giving dapagliflozin, you cut their risk of dying by any cause by 1/3. Now, that is a unbelievable, privilege that you and I have to be able to share that news with our patients. You can cut death by a third. And that's remarkable. That is a game changer for this population. So in the United States, we can see that dapagliflozin really has a role to play in diabetes, in CKD, and in heart failure with growing numbers. So, ladies and gentlemen, the journey of SGLT2 inhibitors in heart failure started with trials that I haven't discussed, that started with EMPA-REG and DECLARE, that I discussed in detail, to prevent disease and diabetes, then looked at ways to treat disease. So it's really been a story of prevention to treatment. It's been a story of people with diabetes to people with and without diabetes. And it truly has been a revolutionary way to think about early intervention with the right choices. And there's no point in waiting for people to develop disease when we have the tools to prevent outcomes. So the 2019 ESC guidelines said it well, that if someone has diabetes with risk factors or established disease, they should get an SGLT2 or a GLP-1, even ahead of metformin. And not that metformin is bad, but metformin, its evidence-based for cardiovascular risk reduction, is not at the same level of what we have with SGLT2 inhibitors or GLP-1 RAs. And what is moderate, high, and very high risk? So someone with moderate risk, who is basically, high risk or very high risk, are the ones you really need to focus on. If someone has had 10 years of diabetes, if someone has 3 or more risk factors or has established disease, those are sort of high, very high risk patients, and they should all be prioritized to receive an SGLT2 inhibitor or a GLP-1 RA. The 2021 American Diabetes Association guidelines also say the same thing, that first-line metformin, after that, consider if patients are at high risk or have established vascular disease, and then prioritize them to receive either an SGLT2 or a GLP-1 RA for cardiorenal protection. And the heart failure guidelines now also say initiate SGLT2 inhibitors irrespective of diabetes status in people with HFrEF. How does this magic work has been a topic of great interest in our group. And I will just tell you that in addition to the indirect effects on renal function, provascular progenitor cells, erythropoietin, sympathetic activity, and improved energetics, these drugs have also been suggested to have potential direct effects at the level of the sodium hydrogen exchanger, CAM kinase 2 delta, mitophagy, autophagy, NLRP3 inflammasome, etc., through which they may have benefits to improve outcomes in heart failure. So I want to just end by saying that clinical trials and drug discovery are only part of the overall solution. The knowledge gained needs to be translated into patient care, something we have done poorly with many classes of medications. If we are to win the war against heart failure, science will need to be coupled with pragmatic and deliberate implementation approaches with the goal of overcoming inertia. And I think that is a really important message, friends and colleagues, that clinical inertia equals bad outcomes. I hear this all the time. My patient is stable, or let's assess him in a few months. I think I'll only use this therapy in people with diabetes. I think it can cause hypoglycemia. There's 1,000 excuses that I hear all the time. But I hope that we're not saying that this is somebody else's job. It really is our job as doctors to be the gatekeepers of the patient's best interest. An ounce of prevention is worth a pound of cure. We have the tools today. We declare TIMI 58 to prevent cardiorenal disease, and we have the tools with DAPA-HF and DAPA-CKD to treat heart failure and renal disease if they were to develop, even in people without diabetes. So I'm delighted, colleagues, to tell you that dapagliflozin has truly come full circle and has now evidence across the entire continuum of cardiorenal protection in people with and without diabetes. Well, thanks so much for your attention today. I hope you found this valuable. I was hoping to stay online and be able to answer a few questions. Unfortunately, I have a hard stop. I have to join another conference call at 11 o'clock, but I'm leaving.